Welcome everybody. The webinar of Foxy Medical Disorders in Pregnancy Committee with Bhiwani, Karnal, Palwal and Sirsa societies. After doing two successful webinars with the Haryana OB/GYN Society, we bring to you the third webinar on high-risk pregnancy. I am Dr. Komal Chavan, Chairperson Foxy Medical Disorders in Pregnancy Committee, and I extend warm welcome to all of you on behalf of Foxy, and I thank Foxy President Alpesh Gandhi, Secretary General Khan, and our Vice President Atul Ganatra for giving us the opportunity and this committee to go into the corners of India with this initiative of Bridging Bharat. Today's webinar is a webinar of topic high-risk pregnancy, wherein we have Dr. Sarita Bhalera, who would be joining us very soon and giving us a lecture on investigations and management in the first trimester of pregnancy. But we have a very eminent panel, and the whole idea of coming together is so brilliantly showcased by these wonderful societies, and these panelists belongs to each society. So may I have the next slide? I welcome Dr. Kamala Bharadwaj from Bhiwani Society. She is the founder of Foxy Bhiwani branch, Deputy Secretary of Haryana OB/GYN, General Secretary of National Wing of National Brahmin Federation, General Secretary of Sant Ganga Nath Education Society, and organized many medical camps for pregnant ladies and special work on eradication of anemia, and has contributed to Shri Ram Van Kutir Ashram and a lot of social work, and also awarded Bharat Jyoti Award, and has also done a lot of social work in Bhiwani. So very great thing. So we are taking the names of all the panelists in alphabetical order of the society. So welcome Dr. Kamala Bharadwaj. Next, we have Dr. Sonam Garg. She is representing the Karnal Society, and she has IVF ICSI Foxy training in Gangaram Hospital, New Delhi, embryology training from Singapore, and Dr. Sonam Fertility Center, which she is running since 2013, Secretary and Chairperson of Karnal OB/GYN Society. Special interest is IVF, ICSI, operative laparoscopy, hysteroscopy, high-risk pregnancy, and adolescent health. So next, welcome Dr. Sonam. We have Dr. Mithilesh Bansal, who is past President Foxy Palwal Society from 2015 to 18, a senior obstetrics and gynecology from the society, past President of IMA Palwal, Best President Lady Award, IMA Palwal, registered member of Haryana Gynec Society, Menopausal Society and other societies. And she was the first lady in Palwal to stop sex determination and abortion before the law came. And first prize is running age above 60. So that is a real great achievement. Welcome Dr. Mithilesh Bansal. Next we have Dr. Ponika Chichi, also from Palwal. She is a gynecologist and IVF specialist. Worked formerly at MAMC Delhi, PGIMS Rohtak, presently running her own nursing home in Palwal. Credits of first IVF baby in Palwal. So welcome Dr. Ponika, nice to have you in the panel. And next we have with us, next slide. Next we have with us Kavita Saharan. Kavita Saharan. She is from the Sirsa OB/GYN Society, the infertility specialist and secretary of Sirsa OB/GYN Society, working as a head of obstetrics and gynec at Department of Apex Infertility Center, Sirsa. So with all this eminent panel and all agreeing to come together on just a phone call to this webinar brought to you by TOG Science Integra with our academic partner Bharat Serum under the initiative of Bridging Bharat. I really appreciate all this, and as Dr. Sarita Bhalera is busy and is having an emergency case, she'll be joining and taking the lecture later on. So without any delay, we will be starting our panel discussion, and I will just share my screen. So panel discussion on recurrent pregnancy loss. Yeah. So Recurrent pregnancy loss is a common condition, and we all see cases of recurrent pregnancy loss in our daily practice, whether you are doing an infertility practice or even endoscopy practice or even a general high risk pregnancy practice. So I recall the phrase by T.G. Thomas. He said, I recall nothing which in times past has caused me more anxiety and doubt, or in regards to which I have found it more difficult to get any satisfactory rules from books than the treatment of abortion. So how this is how the treatment of abortion is so complex, and we have these varied causes and something like a recurrent pregnancy loss, which is really devastating for our patient and very challenging for gynecologists and obstetricians like us. So we just want to know some common questions which are asked. And first question, Dr. Kamala, what are the common questions asked by our RPL patients? They come to our clinic. So usually they are so anxious because they must be going to many gynacs. And what are these common questions? You can unmute your mic to answer the question. Dr. Kamala. Dr. Kamala Bharadwaj? Yeah. Unmute your mic.
Here weather is not good and it's almost storm, so I may you may not be able to hear me in between. My answer in this
I can hear you.
Comes in between. After doing all examination, counseling and taking history, the first question which goes take us to the diagnosis is at what time, what the period of gestation when she has these episodes of losing pregnancy. Means actually the period of gestation is very important, and how means whether it is painless or it is painful. This question we have to ask, which leads us to the diagnosis. These are the questions.
Yes, but there are so many questions the patient has it, like why it has happened, why it has happened with me, will it happen again, can we avoid, what could have been done by that doctor or somebody to avoid it. So these are the patient questions, and we have to tackle this in mind and then go ahead. So how common is the RPL? Dr. Sonam Sachdeva, you can unmute your mic.
Yeah. Good evening, everybody.
What is the incidence of RPL?
Spontaneous pregnancy loss is one of the most common complications of pregnancy. So 70% of human conceptions fail to achieve viability, as your slide is showing, and plus 50% are lost before the first missed menstrual period. Actually, between the fertilization and the implantation, 30% are lost, and between the implantation and the urine pregnancy test coming out to positive, 30% are further loss. And overall, if we see in the pregnancy, before 20th week, around 12 to 15% of pregnancies are lost. So actual rate of pregnancy loss will depend upon when we take off the cutoff for declaring it as pregnancy loss. It's either before the implantation, after the implantation, whether the fetal sac is present or not. So the percentages will differ, but on an average, on a normal population, the pregnancy loss is approximately 12 to 15%. And there are various causes for loss of pregnancy, which may be discussed later on.
Yeah. So these are the general. So what is a definition? So how do we define? Because this RPL is so complex. Dr. Mithilesh Bansal, can you unmute your mic and just give a simple definition of RPL and unmute your mic, please.
Did you hearing, ma'am?
Yes, I can hear you.
Okay. Hello?
Hello, yes. We just asked you a simple thing. What is the definition? What's the practical definition of RPL?
Ma'am, if there are 3 consecutive pregnancy loss prior to 20 weeks from the last menstrual period, or some say before the 24 weeks, it is called as recurrent pregnancy loss. But if the age is more than 40 or 45, we can we can say that after the 2 pregnancy loss, it is taken as a recurrent pregnancy loss, ma'am.
Yes, yes, very good. Very well covered that the age of the patient also is a factor. And we have a primary recurrent pregnancy loss refers to couple who never have a live birth. And a secondary, there may be some patients who have had a successful pregnancy and then following which they have a repetitive loss. So it can also be a primary or a secondary recurrent pregnancy loss. Dr.
Yeah.
Punika, can you just enumerate the causes of this recurrent pregnancy loss in a broad headings? I don't want you to go into very detail, but the commonest what we see in our clinic.
Hello. Ma'am,
Hello, yes.
basically, we think commonly, broadly, we divide the causes into genetic causes, uterine causes, endocrinal causes, immunological causes, infections. These are the common causes, and thrombophilias. And 50% we don't know what is the reason behind the abortion. So idiopathic is one of the important reasons.
Yes, yes, very, very, very nicely said. So we need to keep in mind all these causes when we are evaluating our patients, and we need to know how is the history, the clinical presentation leading us to which of the cause and then treat it. And this is a proposed etiological what you said. So Dr. Now coming back again to Dr. Kavita, is it important to establish the gestational age of these pregnancy? How important is to know at what is the gestational age of the pregnancy loss?
Hello, ma'am. Good evening.
Yeah.
The importance of gestational age of pregnancy losses is, as we are discussing, whether the gestational loss, this pregnancy loss is early pregnancy loss or it is a late pregnancy loss. And whether it is a pre-embryonic less than 5 weeks gestation was there, or it was an embryonic loss for less than 8 weeks, or fetal for more than 8 weeks. For pre-embryonic losses, the etiology could be very different, like endocrinological disorder and in luteal phase defect, like these causes, the loss is pre-embryonic. Whereas in less than 8 weeks, we can say that in many conditions like PCOD, hypothyroidism, and endocrinal disorders, the pregnancy could be pre-embryonic loss, and in embryonic fetal device, the loss of viability is comes when once there is a heartbeat, we see the baby has a heartbeat, and now there is a loss. So USG, it shows embryonic core of more than or equal to 5 without any cardiac activity, then we say it is an embryonic demise.
Yes. Yes. So we need to know whether it's an embryonic or embryonic pregnancy, and what is the actual gestational age is very important in knowing what is the type of recurrent pregnancy loss. So Dr. Sonam, on ultrasound, do you have any milestone by which we can predict the outcome?
Yeah, we have various measurements in the early pregnancy which will tell us whether the pregnancy is going to be viable or not. The various thresholds are of the sac diameters. Either you will have a sac with yolk sac or without yolk sac. If the size is 20 mm and it is without yolk sac, this pregnancy is not viable. Then another indication, another measurement would be 25 mm without embryo, or on transabdominal scan, there is an anembryonic pregnancy that shows it's a fetal loss. Then we need to find out, we have patients who are coming up with the regular follow-up, like we would like to see what the size of the sac is increasing per day. So normally the parameter usually taken is around 0.6 mm per day. And if it is less than 3 mm over 5 days or less than 4 mm over 7 days, then we say the pregnancy is not going to be viable and we've lost the pregnancy.
Yes, very, very rightly said. And so when shall we start the investigation? Dr. Punika?
Ma'am, if patient is below 35 years, we should start investigation after 2 losses. And with those losses, if the patient comes with the second loss, we can send the product of conception then and there only. And if patient is more than 35 years of age, we should consider the investigation after the first loss only, because the chances are more of recurrence.
Yes. So this is very, very important point, which we need to know. The age of the patient is a very important factor. And are there any biochemical markers to predict the outcome, Dr. Kavita?
Hello. Yes, ma'am. The biochemical markers are beta HCG done immediately, and the beta HCG titers should rise double in quantity after 48 hours. Serum progesterone levels 17 alpha hydroxyprogesterone, inhibin A, inhibin pro alpha C, and IGFBP, which practically we don't do nowadays. Till now, we are not performing all these tests.
Yes. So very nicely summed up, and these were the common questions which we have just covered up in a broad spectrum. And now we have very interesting cases on RPL, which everyone is going to discuss one case. And coming to the first case, Dr. Kamala Bharadwaj, we have this patient who has a repeated second trimester losses and also on preterm birth and painless cervical dilatation, precipitate labor. So she comes with an ultrasound. She's going to many doctors, and the cervical length also is less than 15 millimeter. And also the physical examination reveals shortening of cervix. So how is your plan? Because she wants to get pregnant, and we know that she will be again prone to an abortion. So how will you counsel her, and how will you plan her pregnancy later on? Because conception is not a problem. Taking forward the pregnancy is a problem in her.
This whatever given is, it clearly indicates that she is having incompetent cervix, incompetent cervix is there, and for that it depends at which period of gestation she has come to me, and what is the period of gestation of previous pregnancy loss. If she generally with the incompetent cervix loss, there is a termination or she goes in labor, and there is a very short stage in which she expels spontaneous expulsion of the fetus is late first stage or early second stage, second trimester. Now for that, all physical examination routine which we are doing in that general her investigation and examination. Generally, if we do her routine examination, HbBT, blood group, urine examination, sugar and viral marker, and after that even the thyroid and diabetic status also we should know of this patient, because it might be combined with the other diseases also. And after doing this, we'll go for examination, per-abdominal examination. Generally, if she is in second trimester, the uterus height may not be corresponding with this. It may be slightly less because of the descent of the cervix, gravid uterus. And when first speculum examination will indicate at which period of at which stage she has come. Others is a patulous cervix, and or sometimes we can see that there is a bulging of membrane, bluish color. We can see that. In that case, we confirm this. We'll have that either she is having incompetent cervix. We'll confirm it by ultrasound. In ultrasound, there is a shortening of the cervix. That is, if we do the cervix index, that is the length of the funnel plus 1 divided by the length of endocervical canal, the report will be more than 0.32. It confirms that she is endocervical incompetent cervix. In that case, we'll planning for her uncircularized, which may be Shirodkar or McDonald, whatever, or SQ if it is the higher. Then for that if we can reach up to the internal course, we'll go for Shirodkar and Circles, and prior to this we'll give her isoxaprine, this tocolytic and progesterone we'll give, and then after doing Circles, the complete things which will advise is to take rest mentally as well as physically. For that, we'll do counseling that she will have baby, because we have done everything for that, and this positive attitude we should induce in her so that she have mental rest, and the worry from which she is having up till now, that aura will be gone. Then this complete rest and isoxaprine plus the progesterone and antibiotic will help her, and for a week we'll have hospitalize the patient. Then we can send her, depending upon which type of working she is having, she is housewife or she is working, according to that we will give instruction to her. And if we'll instruct, you have to visit us or by phone or being connected. If there is some leakage or there is a bleeding or there is a pain, she should immediately come to us, and then we can help her accordingly.
So the main thing is that the circlage seems to be the classical thing which we can offer to this patient. So most important would be the timing of the circlage and which circlage, which type of circlage to be done. Because we know the contribution of Shirodkar, we know it's a classical circlage and the other types what you have said. So when would you consider the circlage for this
2
patient?
weeks
If the
before.
patient is non-pregnant, if she comes in a non-pregnant state, will you offer a circlage pre-pregnancy?
No.
I think before that, if the history indicates or by examination 6 to 8 Hagas is inserting and we'll find that she is having incompetent os. So in that case, in routine here now we are not doing. We call her 2 weeks prior to the gestation which she has lost previously. If she has that loss at 14 weeks, we'll call her for this circlage as 12 weeks. And then we'll give her Shirodkar because I think at that time we'll be able to reach the internal os and then we can perform Shirodkar to her.
Yes, yes, very nicely said. So this is that very important. The gestational age plays very important, and we need to time the circlage because we don't want to do a rescue circlage in a known case of cervical incompetence. So it's always better to time the circlage and put that stitch. In addition to this, would you consider putting her even on additional progesterones or any additive
Yes.
adjuvant therapy?
That is we are doing. Progesterone is a must and tocolytic agents also, isosprin type we should give and rest, mental as well as physically. And insertion of the positive attitude in that patient is very, very important. She should have that. She will be helped by this circlage.
Okay, so very nicely put all the points. So after that, we know all the circlage which we have discussed about the prophylactic, the therapeutic, the rescue combined. So all these circlages and how to diagnose and how to get ahead with the circlage patient. So now coming to the next case, we have Dr. Sonam Sachdeva. Your patient now is a 24-year-old, married since 5 years, and she gives this repeated history. That is, of course, she has a vesicular mole where an dilatation and evacuation was done. Then she had a missed abortion at 7 weeks. Some pills were taken. Then missed abortion at 6 weeks. That time dilatation and evacuation was done. Now she comes again 6 weeks with blighted ovaries. So this is the 4th pregnancy. So doing her like the other histories, everything looks to be normal. Even the APLA is negative. So what is, and she has come with a karyotyping report with you. That is, the husband is showing 46XY and the wife is 46XX with translocation at 11, 22, Q24, Q13. So there is some genetical problem in this karyotyping report. So how is your planning about doing an missed abortion? How will you tackle her? What about the genetic study? And what other investigation would you like to do? Dr. Sonam.
Yeah, ma'am, in this patient, this is the most difficult one of the patients we usually face in an OPD every day because these patients need to go to a specialist, one thing, then the sample of the one thing, as a patient was first an H mole patient, we need to understand this that H mole is not considered under pregnancy loss. Ectopic pregnancy and vesicular mole are not considered pregnancy losses. One thing. Another thing is we are not sure about this patient whether her beta HCG had come to a non-pregnant level less than 5 before she was undergoing a pregnancy. Because a patient who has H mole before and if she has not been followed up properly or her beta HCG levels are not less than 5, then she will present like this if her pregnancies are not confirmed on ultrasound. The one thing is this, but the retained products of conception have not been subjected to its karyotypic analysis. So for this patient, guidelines say that if you have a first pregnancy which is lost in early pregnancy, second you should take up for the karyotyping, because you can reassure the patient and you can tell about the prognosis of the patient. Now in this patient, as the wife is showing a balanced translocations, genetically the balanced translocations usually do not give rise to a major problem, although they may lead to further pregnancy losses, but within 5 years they are usually having 75% of the patients would have a normal pregnancy. So we need to reassure the patient that these are not recurring episodes. They may be sporadic also, one thing. Then the other pregnancy, the chances of the pregnancy getting, as the number of miscarriages increases, the prevalence of chromosomal abnormality will decrease. Now the karyotyping the products of conception was necessary for this patient after the second loss, but that report has not been taken up. So rule RCOG says that RCOG guidelines say that we need to take up the patient for the conceptions, karyotyping or genetic studies, so that we can have a prognosis for the patient and we can reassure the patient regarding whatever she has to plan for the future pregnancy.
Yes, yes, very important, because the RCOG guidelines clearly mentions that we need to send the karyotyping, and the karyotyping should have been sent earlier, but whenever now she's come, never late than ever. So it's better to send for the karyotyping, and also the counseling, very important, as the prevalence of chromosomal abnormality will decrease as the number of miscarriages increase. So we need to send the karyotyping. These are the studies which show that a subsequent pregnancy, there is always an improvement in the pregnancy outcome following and genetic or a chromosomal or an aneuploidy. And we need to counsel these patients. So all this is, what is the role of paternal karyotype in this, Dr. Suna? Is it important to send the father's karyotype also?
Majority problems because of the majority cytogenetic abnormalities are due to the mother, but DNA of the father also plays a role. So sperm DNA fragmentation levels are important. Although RCOG guidelines, they say they may increase or improve the level, but the studies are insufficient to prove the role. One thing is this, and the mother's age has a major category, because any lady who's above 35 years of age will be more prone to aneuploidies, which is the most common chromosomal abnormality which occurs in case of these ladies will have recurrent pregnancy loss. One thing. Then another thing is there are certain translocations which will be inherited. If suppose Robertsonian translocation between 11 and 21, which is one of the most common translocation, which will have a chance of getting rise to Down syndrome in the later pregnancy. So they have to be counseled regarding this, that if they get pregnant with this kind of a translocation, if it is present in one of the parents, there's a high chance that the child will have a Down syndrome. So she may need screening after she gets pregnant. Another thing is we have to reassure the patient that the balanced translocations are usually safe and do not lead to recurrent pregnancy loss, the way unbalanced translocations usually lead to recurrent pregnancy losses. So translocations can be of various types, and the various chromosomal abnormalities which may be present. So we have to tell accordingly. Accordingly, the most common translocations are usually balanced translocations or Robertsonian translocations. Translocation is a type of where a segment of chromosome is replaced in the other chromosome. So the DNA is exchanged between both the chromosomes. So the gene loci changes, which leads to various problems in the progeny. It may lead to mental retardation, it may lead to demise of the fetus, it may lead to infertility, which are the most common results of translocations. One of the Robertsonian translocation is for acrocentric chromosomes, in which the one arm is short and one arm is long. When two acrocentric chromosomes exchange their long arms, so they form a chromosome which has the maximum chromosomal material with two long arms, and they form one small chromosome which is like a dot or a microchromosome. So this chromosome is passed on to the further generation. The patient will have one of the chromosome extra. Number would be less, but because of the long arms present in one chromosome will behave as an extra chromosome that will result in Down syndrome. That I recently gave an example of translocation between chromosomes 14 and 21, which is one of the most common combinations, will resulting in Down syndrome.
Yes, this is seen in the picture also very well, as you said, and very nicely explained about the Robertsonian translocation. And Down syndrome is something which we are almost worried, and we need to counsel our patient for that. So this is all how the Robertsonian and trisomies, other trisomies are also there. There is a deletions, lot of genetic things are there. There are also the Cri-du-Chat syndrome, which is genetic. Then the counseling and the PGD to this patient to offer them is very, very important to these patients. And definitely, if we know the karyotyping of the parent, genetic counseling after a miscarriage is the most important thing, which and also referred to a clinical genetist to this patient should also be done very, very promptly. So we come to the third case, Dr. Mithilesh Bansal. You can unmute your mic. We have a 38-year-old, 28-year-old, sorry, she's married since 6 years, gravida 4, para 1, living 0 with 3 abortions. The first was a preterm stillbirth at 7th month due to abruption, and then following which she had 2 missed abortion and then 1 spontaneous abortion at 6, 8 and 8 weeks. So this is a clinical history and she fits into a recurrent pregnancy loss. Rest, menstrual history, medical history, everything looks normal. On investigation, she comes with a report to you. She has a toxo report, and this is the report which she shows you that toxo IgG is positive, rubella IgG is low positive, CMV IgG moderate positive, herpes IgG mild positive, and these are the other investigation what she comes, in which the ACL also is IgG high positive, IgM also is high positive, LA is high positive. So this is her PT, bleeding time, everything. She has an autoimmune profile, everything done. She's a workup patient. She's come for your opinion. So what do you think about this torch and the other reports with the autoimmune profile? What is your impression about this patient? Dr. Mithilesh. Hello.
Hello?
Yeah,
ma'am. First, I say thank you, Dr. Komal, for giving this opportunity as a panelist from a very small district. You are so encouraging and cheerful personality. Thank you, ma'am.
Thank you so much.
This case has 3 recurrent pregnancy losses, that is 7, 6, 8 weeks, and 1 premature 28 weeks stillbirth. This case has toxo, rubella, herpes, cytomegalovirus, and in this case, IgG is positive and no IgM positive. So this is a infection is a past infection, not recent infection. The latest guidelines of FOXI that you should not investigate for TORCH, because TORCH is not the cause. TORCH, toxoplasmosis, rubella, cytomegalovirus, or herpes is not the cause for recurrent pregnancy loss.
Yes.
This patient has anticardiolipin, antibody positive, IgGM positive, double standard DNA is positive, lupus antibody is positive. So this case seems to be, according to history and blood tests, a case of APLA associated with systemic lupus erythematosus. It is a condition causes recurrent pregnancy loss, and this cause PIH, stillbirth, premature delivery, and baby is born. Heart disease is very chances of heart disease. First of all, the history is very important in this case. Previous history of any clots in legs, lungs, stroke, visual loss, history of epilepsy, thyroid, diabetes, or high BP, smoking, alcohol. History of diabetes is very important because there is a family history of diabetes. and hypertension. Past history, previous pregnancy, history of pre-eclamptic toxemia, blood pressure, about baby fetal growth retardation or weight of baby if possible in previous pregnancy which is delivered still worth 7 months. Repeated 3 recurrent pregnancy loss and history of cardiac activity present or not, or history of bleeding or any drugs like antithyroid or any hypertensive drugs for BP or any injection, any history of taking aspirin or low molecular weight heparin in previous pregnancies. Investigation, I will like to do routine investigation.
So
CBC
before we come to the
platelets.
investigation, so you rightly said about the RCOG guidelines. All the guidelines say that a routine torch is abandoned. But
Yeah.
if at all you have to know about any infections, which infections are more important, which really we should look into our patients, and which are like torch is definitely we need not pay attention to the torch report. There are so many people who still do it. We have patients coming to us with already a report, we can't help it. But apart from torch, what are the other infections which you actually should be screening for this patient to just rule out any infective cause?
We should rule out, madam, other infection like brucellosis, Zika virus, parvovirus, influenza, malaria, and near future it may be COVID also. And second is
COVID with recurrent pregnancy loss, we don't know, but
we don't know,
definitely
but near
tuberculosis in
future,
our
near,
yeah. So
near
there is
future
no
it may be. And tuberculosis is one of the very important cause for recurrent pregnancy loss. It causes tuberculosis of endometrium, ovary, or pelvic tuberculosis called syncytia and recurrent pregnancy losses. Bacterial vaginosis is also very important cause. 60 to 70% have recurrent pregnancy loss in bacterial vaginosis, cervical, endocervix, cervicitis, uterine infection is also important cause of recurrent pregnancy losses.
So we need to know this recurrent pregnancy. Now coming to your APLA. So we know that the APLA definitely causes the recurrent pregnancy loss, and the mechanism is because of the inhibition of cytotrophoblast invasion, differentiation. There is also thrombosis. That is the reason the coagulation profile was done. There is a fibrinolysis. The coagulation cascade is all disturbed, and arachidonic acid release it blocks the PGI2, which is PGI2 is decreased, and cytokine action against the interleukin 3 and placental cell apoptosis. So all these mechanisms play a very important role, and APLA is a very important factor in this recurrent pregnancy loss. And if we don't know of all the investigation, if we don't know that what is the cause, it's always better to do the autoimmune panel and arrive at the diagnosis. So when we have a case of APLA, what is the basic management? How do you manage this patient?
Ma'am, first do we investigation for CBC, platelet, INR, prothrombin, KFT, LFT, lipid profiles, and TSS, T3, T4. Urine is also very important for proteinuria and pus cells. Some special tests we will do because there is a because lupin antibody is present, cardiolipin anti-cardiolipin antibody is present. Then anti-cardiolipin antibody test should be done. Anti-lupus antibody test should be done. Anti-nuclear antibody test should be done. And double strength BTT, kaolin, if positive, and it should be repeat after 3 months also. 2 investigation twice. We repeat twice because we don't believe in one investigation one time, so we have to repeat twice. And in management, sir, madam, pre-conceptual counseling is very, very important. In these cases, there is emotional bonding, and psychotherapy is also very take a great part because they are very nervous, they are psychologically embarrassed, and due this psychological trauma, and second is ask for lifestyle modification. As patient is obese or overweight, to reduce
for the aspirin therapy and the low molecular weight.
I will tell, ma'am.
Yeah.
I will tell. To reduce weight for healthy food, start folic acid 5 milligram BD prior to conception at least 3 months before. Start HQ tablet, Plaquenil tablet 200 milligram before the conception at least 2-3 months before. And small doses of prednisolone 10 milligram BD may or may not be given. It is controversial. Give low doses of aspirin 50 to 75 milligram before conception at least 1 month before. Proper checkup after conception and ask the lady report immediately, even 2 or 3 days missed, because this is very important. We, if there is a missed of 2-3 days, we do UPT test, and if it is positive, we start, madam, low molecular low LHMW, and we don't wait the cardiac activity is there or not. Just by going UPT positive, we start this test, and usually given 40 milligram per subcutaneous before the appearance of cardiac activity, and it should be continued up to 36 weeks along with, because there is a SLE and lupin test is positive, so we continued HQ tablet also along with aspirin 75 to 100 milligram. Regular fetal monitoring of the mother and the baby is very, very important. Keep a watch on blood pressure and proteinuria, because there is a chances of nephritis and other vascular diseases. First trimester ultrasound, normal pregnancy or biochemical test, we do beta HCG and serum progesterone. Second trimester follow up, BP, proteinuria, and 24 to 26 weeks we do color Doppler and continue aspirin and low molecular weight heparin. In between, we can do the investigation prothrombin time and second time anti-nuclear antibody again. Watch for pre-eclamptic toxemia, IEGR for this. And surveillance is very, very necessary. In third trimester, stop low molecular weight heparin at 36 weeks for delivery, and risk and complication of during delivery, we keep a special surveillance. Do not give carboprost for PPH in this case, because there is a history of bronchial asthma childhood. After delivery, 24 to 48 hours, we again start low molecular weight heparin for 6 weeks to prevent thromboembolic phenomena.
Yes, yes. Very nicely you have said about the low molecular heparin, but in addition to the low molecular heparin, we give aspirin. We can also consider the normal heparin or even prednisolone. And there is also a role of immunoglobulin, because the immunological, because almost 45% of miscarriage and 95% of late pregnancy losses from women experiencing RP are chromosomally normal and they are immunological. So definitely there is a role of immunoglobulin which we can consider giving to this patient. And
immunoglobulins can be given.
Yes.
Immunoglobulins can be given in case of acute case 1 microgram per kg of body weight for to decrease autoimmunity, and it can be repeat after 3 weeks. 3 weeks, but there are controversial and there is no fixed RCOG guideline that key immunoglobulins are helpful, but they decrease autoimmune disorder.
Yes. So these are various studies. Even I haven't studied in comparison when the immunoglobulin is given after many abortions, like more than 4 or 5 abortions, they show significant improvement in the pregnancy outcome, and that is the reason the immunoglobulins are recommended when the immunological factors are present for the recurrent pregnancy loss. Also, the coagulation defects, we know that the patient can have either a thrombophilia and they are at risk of DVT. So all these analysis we need to keep in mind, and only when we have a patient we need to see if there is a deficiency of any of the factor 4 or factor 2 or protein S, antithrombin, and that will increase the risk of DVT. So we need to monitor all the factors. And correction of also hyperhomocystinuria is also very important in addition to the low molecular weight heparin therapy, which Dr. Bansal has said very well about the low molecular weight.
And
Thank you
we
very
also,
much. Yes, you
madam,
have
we
covered
give
it very well.
immunotherapy. We
Ma'am,
also give
We will
immunotherapy.
go to the next
Immunotherapy.
case.
Ma'am,
Yeah, we have covered the immunotherapy
ma'am,
now.
I just want to ask
Yeah,
one
yeah.
question.
What do you want to? Yes.
Ma'am, just comment upon, you said that CMV was positive in moderate titers.
Huh.
So, in the early pregnancy, can we do something to exclude any complication? I
Actually,
am
Yeah,
talking about
we
whether
do,
to go
and
for
we do
all
ability test. We do the ability test. If this is low, then chances of infection within 3 months. If it is high, then chances of infection more than 4 months. And if infection is there, that we do MTP for if there is
then we
a
can go
infection.
for further investigations and confirmation of the infection.
See,
We give
ideally, when you know about the CMV and anything, only if the IgM is positive, we need to little bit worry. But if a report comes with IgG and all, it may be a past infection. So actually, we don't have to give that much importance to the torch report which the patients are carrying. But if there is an infectious cause, we need to rule out the other infectious causes which we very well nicely discussed and give importance, because many people are doing torch, but it is
That's
not
why,
the cause.
ma'am,
Cause of
patient come with the reports which are positive. Recently, I have a patient with polyhydramnios whose CMV was positive around 24 weeks. I explained her many times that it is IgG, nothing to worry.
Yeah, I think it's a past infection. It may be any time. It may be pre-pregnant. So we don't have to treat that. There may be other causes of that polyhydramnios or other causes which we need to see, because if we are stuck with that torch, we may ignore the other causes. And we know that the recurrent pregnancy loss is such a wide spectrum of causes, and we need to analyze everything. So proper counseling to these patients are very, very important. So now, Dr. Kunika, it's your turn only. And your patient is 33-year-old, married since 10 years. She's again a gravida 5 with no living and 4 abortions. Now she's come with 6 months amenorrhea. There is no significant family personal history, but she has a very complicated obstetric history. Like she had a 2 months missed abortion. Suction evacuation was done 9 years. Then she was planning a pregnancy, but she had a malaria and she was admitted, hospitalized, and she was very scared of taking the treatment which she tells. So she wanted an MTP. So again, an MTP was done, a surgical one. Then again, she had a second 2 months amenorrhea, and it was a missed abortion. So again, suction evacuation was done. Again, she had a missed abortion. Again, suction evacuation was done. So she had all these histories. And now she has come to you in the present pregnancy. She has come again. There is a missed abortion, and suction evacuation is done. So this pregnancy also has failed. So now, what do you think? What must be the problem about repeated suction evacuation? And now she has an amenorrhea, wherein the UPT is negative.
Ma'am, if she is having amenorrhea after multiple DNCs, most probable diagnosis is definitely Asherman syndrome, and
Yes.
cause is DNC itself. Diagnosis can be confirmed by hysteroscopy, and simultaneously we can treat it at that time only. So we can just convince the patient for diagnostic as well as operative hysteroscopy at the same sitting, and we can plan for it. And after removing the synechia, depending upon whether it is a partial or a complete Asherman's, then we can go for estrogen therapy and used to give estrogen for prolonged duration, so that she will have bleeding herself without progesterone, and then give 2-3 months of estrogen followed by progesterone, and then she can plan again.
The pregnancy, yes.
Ma'am, normally I don't put IUCD, and till now I don't have any problem.
Yeah, I was going to come
Only
to
after
that.
estrogen I have good results.
So
I don't
what do you use after not IUCD? Then you will just.
Ma'am,
put the
I don't
estrogen?
put anything normally. I just used to give high dose of estrogen TDS for prolonged duration without, till she will have bleeding itself. I will give it for longer duration, and a
Okay.
one course of antibiotic, nothing
How
else.
long
No
will you give
Foley,
the
nothing.
estrogen therapy? How long?
Ma'am, normally it take 40 or 50 days, after which she will have bleeding.
Okay.
because of overgrowth of that endometrium.
Yes. And how
And
common is the Asherman's in your like you see many cases of Asherman's?
ma'am,
How
ma'am, patients are common, but actually the history, mostly the patients came later. In cases of recurrent pregnancy loss, it is common almost in 10-15% cases. But I feel more patients are there with complaint of hypomenorrhea, oligomenorrhea, but their families are completed, so they are not bothered about it. So don't come.
Yes, yes. This is very important that patient is having an Asherman's, but they have not come unless the menses totally stops. Then they come
Yeah.
with amenorrhea, and then when we investigate, it is not a pregnancy. They come like saying that you are pregnant, but it is a amenorrhea, and totally there is all adhesions when you put in a scope, and this is the classical Asherman's case. And definitely, the treatment modality is surgical thing which we need to do, and the estrogen therapy which you stressed upon is really very important in this case. And how do you see the improvement in what is the pregnancy rate after the therapy? How you have seen in your practice, Dr. Punika?
Ma'am, in my practice, I have no problem. Till now, I did around 10-15 cases of Asherman's, but I have no problem. There was not a case of complete loss, meaning by grade 4 is not there. Usually they are grade 2 or 3, and in those patients, results are very good, satisfying.
Very good. So good. So this is one of the good cause. If we can treat the patient, identify it right time, and give a proper treatment, definitely we can improve the pregnancy results. So we need to diagnose the Asherman, and the hysteroscope is the treatment of choice for this patient. And we
Ma'am,
should
only thing
not.
is if we understand that we should not overcure it, that is a
Yes.
simple thing which we learn from MBBS days, but we usually don't follow because of the chances of bleeding. We are slightly a little of fear of ki she will have bleeding, then she will come and ask me
Yeah,
and
this is
argue
a
with me.
lesson to learn that you should not
Yeah.
overcure it when you're doing a normal DNC or MTP. So this actually leads to this problem, because many procedures, and that also with overcurettage and damage to the entire endometrium, and this happens. So definitely the lessons learned while tackling the patient in the pregnancy losses and identifying at right time and achievements can be give a good result also later on. Thank you so much. So we come to the fifth case, Dr. Kavita Saharan. Your patient now is 35-year-old with 3 abortions, all 3 missed abortion at 8, 7, and 10 weeks missed abortion. And this is the investigation report she has come. She gets pregnant, she has a missed abortion. And all investigation was done when this time there is a day 2 progesterone level was done, which was 2, and the day 8 progesterone level was 8.7, which was significant, so mentioned here. And endometrial biopsy also was done, which was showing that there was a lag of 3 days, and USG suggestive of lack of endometrial echogenicity on the 7th post-ovulatory day, and luteinized unruptured follicle and lutein cyst formation. So it is actually, the things are written very simplified manner just to make it very clear and arrive at a specific diagnosis so we can discuss it. So what do you think, Dr. Kavita? What would be the probable cause? And this is one of the most commonest cause actually, which we are coming to of recurrent pregnancy loss. So, Dr. Kavita, you can unmute your mic.
Hello, ma'am.
Yeah.
Yes. Hello. Can you hear me?
Yes, sure.
Hello.
Go ahead.
Hi, ma'am. So, as we all know, luteal phase is the time between the ovulation up to the establishment of pregnancy or up to the onset of menstrual cycle. So, in the luteal phase deficiency, this cycle is shortened and it comes less than 12 days, and either the establishment of pregnancy or onset of menstrual cycle occurs due to inadequate projection of progesterone from the corpus luteum or inadequate response of the endometrium to the normal concentration of progesterone, RPL occurs. So there is around 3.5% incidence in infertile couple, and luteal phase deficiencies incidence is up to 35% in recurrent miscarriages. The diagnosis is very controversial. Basically, it is very difficult to diagnose, and most of the time, it is overdiagnosed and overtreated. Theoretically speaking, as I remember, we have been told that the only diagnosis for luteal phase defect is only histopathological diagnosis, where if secretly endometrium is lag behind 2 or more days, as in this patient it is shown. Now, practically speaking, the appropriate time for doing anti-endometrial biopsy is between day 6 to day 10 of post-ovulatory period, and this is the best window period for the fertilization also. So, practically and logically speaking, timed endometrial biopsy is nowadays absolute, and we have to perform repeated serum progesterone levels. Any level between 8 to 18 nanogram per ml of progesterone is normal, and anytime if the progesterone level in post-ovulatory phase is less than 10, then we should suspect that it is
Yes.
luteal phase deficiency. So now comes the management part, as we all know. So we should always keep our eyes open. Do TVS frequently to look for the important secretory changes. Do progesterone levels and individualize the progestins. The natural micronized progestins are the best for this treatment. Any we have to individualize the root of the dose and frequency of the progestin. It is very important to know when to start. One day after ovulation, if it should be started, but if we start very early, the progesterone changes and shifts the window of fertilization earlier, so pregnancy rate decreases. Vaginal route of progestin is the best considered because the dose is required less. There is maximum absorption rate because vaginal route the GI tract and liver first metabolism bypasses. And we should also know when to stop the progestin in these patients. If we are treating a patient solely with luteal phase deficiency only, then it should be started next day after the ovulation, and it should be continued till the pregnancy comes positive. But if there are any other comorbidities like we think that we need to give her more progesterone like in PCOD patients or recurrent pregnancy losses or hypothyroid patients, then or whether it's a very spacious pregnancy, then we can continue this progesterone up to 10 to 12 weeks of pregnancy.
What about HCG?
My
What is the
next question
experience
is,
with HCG?
ma'am, in some conditions we have seen like in endometriosis, whether it is an inflammatory pathology, but in the patients where the endometrium is not responsive to the progesterone, it is progesterone resistant, or it is reduced, the sensitivity is reduced to the progesterone, then the role of SCG comes. At it is given 10,000 units iron stat and then 5,000 bi-weekly until the UPT comes positive, and once the patient is pregnant, then we shift this SCG to a weekly dose.
Yes, very, very rightly said. And we need to know that there are also, we discussed the luteal phase defect in detail, but the main thing is that we need to also know that there are other hormonal defects also will be there with RPL, and we need to also rule out hypothyroidism, which is one of the medical disorders in pregnancy, very common, and hyperprolactinemia also in this patient. So these all and diabetes, or if the poor insulin glycemic control like PCOD. So these patients with luteal phase defect may not be with only with LPD, but maybe having an underlying pathology. And we need to know all these things. And this was a very interesting article which I had come about the the proteomic analysis of recurrent pregnancy loss patients showed that there was an inadequately expressed set of proteins in the human follicular fluid. So this follicular fluid analysis also gave a diagnosis of patient with having spontaneous abortion. And we have discussed progesterone, and there are other. So I think we have very well discussed all the factors of recurrent pregnancy loss, everything very well, and we very nicely discussed with all the panelists that about progesterone in detail, what is the role of HCG, everything has been done, and we have our speaker also, Dr. Sarita Bhalera, who is ready. So we need to. I just want to now sum up the entire panel what we did it about the evaluation and management of RPL. So we need to know which is the factor, whether it is an immunological factor, then we need to diagnose with the immunophenotyping test or embryotoxicity assay. The result is 15 to 20% and the therapy is our heparin, IV immunoglobulin, immunological therapy. But if there is an parental structural chromosomal rearrangement and we know we are tackling a genetic and cytogenic assessment of both the partners, even of the conception, this is very, very important and we need to give them genetic counseling. Probably this patient may require a donor gamete or PGD in later part. If we know it is an endocrinological factor, we need to do an endometrial biopsy in this patient, mid-luteal progesterone analysis, TSH, prolactins, sugars are very important. The therapy in this patient would be the progesterone therapy, correction of the thyroid with levothyroxine, thyroxine, bromocriptine, cabergoline, metformin, insulin are all the treatment which we need to keep in our mind. And the abnormal results are around 8 to 12% of the RPL, wherein the anatomical factor is contributing to 15 to 20%, and the diagnosis is by hysteroscopy, HSG, or even sonohistography. And your hysteroscopic metroplasty, adhesiolysis, myomectomy, or any anatomical defect correction is really very, very important to sum up. If we have thrombophilia and we have all this factor 5, prothrombin gene, or antithrombin activity protein S or C, which is around 8 to 20%, low molecular weight heparin and folic acid, which was very well mentioned in the panel, is the therapy for this patient. And if it is microbiologic, that is endometrial biopsy, cervical vaginal cultures, and any infection swabs and everything need to be taken, and the therapy is antibiotic therapy for this 8 to 10% of patients. So we need to know which type of RPL which we are managing, and then treat and not forget the psychological aspects of RPL, evaluation of mental evaluation, and also referring patient to a support group and also taking help of psychiatrists if wherever required. And there are also iatrogenic in some patients with use of drugs, caffeine, any toxin exposure. We need to do genetic counseling, and if the worst scenario in this patient having repeated failure, even donor gamete and PGD needs to be added to these 5% of cases. So we need to know what are the causes of RPL, treat them accordingly so we can give a good outcome to our patient. And with this note, I thank you all for having an excellent discussion and giving very good take-home message for our audience. And thank you very much. And now I'm going to stop sharing my screen, and I would ask Sana to share the CV PPT of Dr. Sarita Bhalerao, and without any doubt, Dr. Sarita Bhalerao is here with us, and we begin with our talk on investigation and screening in first trimester, which is so important. After knowing this recurrent pregnancy loss, we need to know which investigations and how we would do in this high-risk patient, what is the correct technique, and when to do this investigation is very, very important. And for that, Sana, please share the CV slide. So I welcome Dr. Sarita Bhalerao, and she is here with us. She had an emergency high-risk case of fetal distress and had to run, but has come on time very well to give a very, very informative talk to us. And I know Sarita Bhalerao very well. And before the CV slide come, I would like to go ahead with the introduction. She is Vice President of Mumbai Obstetrics and Gynec Society, a very senior practicing gynecologist in the city of Mumbai, in the South Mumbai, and she was also the Joint Secretary of FOXI in 2017. She is also the member of the ICOG group, very active in FOXI, in MOGS. She has a lot of awards and a lot of publication and applauds to her credit. And Sana, are you here?
Thank you, Dr. Komal.
Yeah. I think you can share your screen.
Sure. If I can be allowed to share my screen, I'm ready with my screen.
Yeah, you can share your screen.
Can you see my screen?
Yes, I can see your screen. Very well. Yes, you can start.
Shall I start?
Yes, yes.
Thank
can
you.
start.
So good evening, everybody, and thank you, Dr. Komal. A big thank you for inviting me to participate in this webinar. I must say I enjoyed thoroughly the panel discussion, so I'm glad that I was a little late, though I'm sorry for the inconvenience. So I'm going to speak to you today on a little personal experience and what are the investigations and screening in the first trimester. And I'm sure you'll all agree with me that what has changed in our obstetric practice, 20 years, 25 years ago, patients would register in this after 28 weeks. And many, many things would be discovered only at 28 weeks or 30 weeks or even beyond. Even twins, I remember in my residency, used to come at the time of delivery and we realized they were twins. But that is now almost unheard of. And what has changed is that there's been a paradigm shift and the importance of the first trimester has been identified. And really today, obstetric management of the first trimester is one of the key cornerstones how we can prevent and improve our outcome in pregnancy. Now, antenatal care is systematic medical supervision of women in pregnancy. It's a great preventive branch of obstetrics. And the idea is to preserve the physiological aspects of pregnancy and labor and prevent or detect any pathologies as early as possible. At the same time, we can improve the psychology of the mother and instruct her regarding her hygiene and care of the baby. And our objective is to have a healthy mother and a healthy child at the end of this. And what are our failures? Our failures are when we have maternal mortality or we have maternal morbidity or we deal with a fetal death or we have infant morbidity and mortality. And thankfully now all these figures are steadily on the decline and we are really very fortunate that obstetric care has improved tremendously. So as I said, there's a paradigm shift and our focus is now on anticipation, management to health promotion and prevention. And just like COVID, where we're looking at prevention and we're all eagerly waiting for the vaccine, today preventive medicine is more important than anything else. And it's a huge branch of medicine. So we are looking at healthy mothers, healthy babies, and even healthy women leading to healthy mothers and healthy babies. So let's start at the very, very beginning. And this is a case where a patient had her last period on the 8th of May. She felt sluggish and nauseous on the 10th of June. And her UPT was weekly positive on the 10th June. And the first investigations that we always do in pregnancy are the urine pregnancy test and the serum beta-HCG. So the question here is how early is the UPT positive? Can we rely on it? And how early is the beta-HCG positive? So what we know now, if you look at this, is that the beta-HCG is positive even before the first missed period and can be positive almost 10-12 days after ovulation. But the urine pregnancy test is almost always positive around the missed period time. So I think that a simple urine pregnancy test is a very, very good investigation. And if it is weekly positive, then we must go for a beta-HCG. If it is negative, it's most likely negative unless the patient has irregular periods or delayed periods, you can repeat it later. And if it is positive, then it's definitely positive. So where do we use the beta-HCG then? Well, the beta-HCG, if you look at this, steadily starts rising from 3-4 weeks onwards. A beta-HCG over 5 or over 10 is taken as a cutoff point for pregnancy. We also know that the beta-HCG, I think in the panel was discussed that it will be doubling. So a steady rise in the beta-HCG is perhaps much more important than one single value. And the threshold value of 1500 beta-HCG is important to rule out an ectopic pregnancy. Above 1500 or definitely above 2000 beta-HCG, one should see an intrauterine gestational sac. Otherwise, it is a ectopic pregnancy. Many patients come with rising beta-HCGs and they think that, many people feel that we can use the beta-HCG for viability. But I don't think that is possible. The beta-HCG is good to localize the pregnancy, after which you need a sonography. So now we look at a 25-year-old primea gravida, low-risk patient, spontaneous conception, came for antenatal care. She's 8 weeks pregnant. Her history and clinical examination are not significant. And we go for what are the investigations we would advise? So the first thing is, of course, then the maternal start talking about diet modification and possible walking and basic exercise. If she's underweight, this is
We seem to be having some technical challenges at Dr. Sarita Madam's end. So request the viewers to just hold back maybe for a minute or so. We'll just rectify this shortly. Thank you.
Station. Hello. Just connect with Dr. Sarita Palera.
Yes, ma'am. Yes, ma'am.
Madam. Dr. Komal, you would have received some questions from the audience.
So if it's taking time, I can take a question. We can discuss one. Okay.
Yes, ma'am.
Yeah, so you can just do that. So there is a question about the role of atosiban in case of incompetent cervix. So Dr. Shashikant Bawar from Malegaon is asking. So anybody has any idea about use of atosiban? I think Dr. Kamla Bharadwaj was answering the question about incompetent os. So any studies or anything you have encountered or used in your practice, or any of the panelists has used atosiban? Hello? Yeah, Dr. Kamla?
Can you hear me?
I can hear you, yeah.
I can't see, I can't hear anything.
Yeah, I can hear you. You can talk. Yes? Anybody has any role? Because here we have a study of atosiban happening in Mumbai at Sion Hospital, and it is given to usually to the preterm patients. Maybe in second trimester also it is tried. But I wanted to know the experience from that side of the country, whether you have any studies about atosiban being given.
Ma'am, we are not using because it is very costly.
Only the cost is the factor.
We are not using.
Not used at all. Okay, because this was a question which has come, and we thought we would know about the trends of practice which is happening. So it is not used. So
they are claiming it is a good drug, but it is very costly.
Yeah, so it is. We have a study going on. It is agreed the cost is a factor, but at times, when we know that the patient is a high risk, and if we have to offer, we should know that this is an option also available. So it's not used that side. A lot of questions about the cerclage only part. I am not able to see Dr. Bharadwaj here, Kamla Bharadwaj. So there is a question: can McDonald cerclage be done as an interval cerclage in patient with one missed abortion and second trimester abortion for incompetent cause? So as we know that the classical cerclage, what we do is usually the Shirodkar which we do in a non-pregnant or an interval cerclage. But somebody, Dr. Jaya Rai, is asking, can a McDonald cerclage be done?
No.
Actually, ma'am, I also don't think that MACD should be put McDonald, because anatomically it is not at the level of isthmus. So it won't serve our purpose of doing an interval and cervical encerclage in this case.
And there is no advantage also. We have to remove after pregnancy once she will receive
And
term.
at our institute, we have a practice of putting an abdominal encerclage because once if a patient is going to such a stage that
Yes.
she has to apply an interval MACD, it means that her uterus is not able to hold the fetus beyond 14 weeks also. Then in interval cervical encerclage, it should be done abdominally.
Abdominal.
Okay. So it's always better to do an interval circlage. The abdominal is a classical, followed by even if we do a high circlage, the
Or
Schroeder and the
high.
anatomical internal loss. But McDonald is usually not to be done as an interval circlage only when we know a patient is already pregnant. So that is a common consensus of the panel. And Dr. Kiran Shah is asking what time duration the prednisolone is given in RPL. So, what about the prednisolone? We talked about the immunological factors. Dr. Mithilesh,
Yeah,
For the first 10 days when you start
what about the prednisolone in
ovulation induction.
RPL?
prednisolone is given in low doses in cases of RPL. It is given easily in first trimester, 5 milligram BD, or we can give methyl prednisolone 5 milligram BD for 5 days, and it can be tapered slowly.
Yes. So,
When
Or
we
it
use
is usual. It is useful in autoimmune disorder where is APLA antigen antibody are present in cases of SLE or in cases of thyroiditis. It can be used.
yes. Yes, but
Ma'am, and
we,
I would like to add one point also. Around 20 to 40% of RPL, we have found that patients are PCOD. So in
yes,
PCOD, when we are doing ovulation induction, we have a practice of giving the steroid for first 10 days along with clomiphene citrate or letrozole. So this will look after the minute immunological factors which PCOD is affecting during
ideal,
the conception.
so it is given earlier only you start prednisolone in these patients.
Early
And what
during
about the
induction.
low molecular weight heparin? There is also a question here that after the cardiac activity, is LMWH given after the appearance of cardiac activity?
It works a lot because in our area the patients are very poor. They cannot afford low molecular weight heparin from preconceptional time. So we have a practice. If the patient is not having a 3 or 4 recurrent losses with like such 1 or 2 abortion history but missed abortion, when the loss has occurred after the cardiac activity has come, we start low molecular weight heparin.
But it is guidelines. It is given before the cardiac activity appear,
Ma'am,
ma'am.
the
Yeah. So what is
guideline
the
is
role?
given.
Whether can we start and even not about a prednisolone, about the LMWH low molecular after the cardiac activity, you have missed it to give initially, and now is there
when
any
we get,
role?
Ma'am, we have seen
Because
good results with
when we
after
can
if
start,
we start
Because,
late
madam,
also.
it is because
when
it decrease proactivity and decrease inflammation process of helper T cells TH, interleukin 2 and cytokinins 2 and tissue necrotic activity. Hello?
Okay. Yes, 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 yes. Got it very
So,
well. Yes.
so this is very good role before do start cardiac activity. So it increase the impermeability of endometrium, chorionic villi, and good implantation after cardiac activity. Before after cardiac activity, sag will disturb. So it is given before the cardiac activity, ma'am.
Yes, yes. So it ideally it should be started before the cardiac activity for better outcome. But if we
can start.
know, if there is, we have missed to start, it is always better to start it because it's giving a good result. Yes, Dr. Punika, you want to add something?
I think we can start till 12 weeks or I think around 10 weeks because whenever we can start, placenta is not formed till 10 weeks. So if we
No,
can
no,
start
no.
10 weeks, then it will decrease the chances of thrombosis and continue the cardiac activity. Otherwise, there may be loss of cardiac activity after some time if previously she had 2 losses. What is
Yes.
the
No,
harm?
ma'am.
Because
No,
placenta is
no.
not formed till
No, no. It will not cause the loss of cardiac activity that much.
No, ma'am, it will not cause. It will help to maintain, not to
maintain the
loss.
cardiac activity.
But
Yeah.
it is not started after 10 weeks. Otherwise,
Ma'am,
it is started.
no, ma'am. I am saying you start as early as possible. But
Okay,
if
so
you
then that
can't,
is well
you can
taken.
start. Late,
That
you
point
can
is
start.
well taken. I have a question now related to the Asherman's case, and the question is by Dr. Kamal Bakshi, madam, and she's asking what is the role of repeat hysteroscopy in this patient after doing the adhesiolysis and Asherman's. Is there any role of repeat hysteroscopy?
Ma'am, I am not doing repeat hysteroscopy in all the patients. But if you feel that endometrium lining is not properly formed on TVS after giving estrogen, you can perform repeat after 4 weeks. But if endometrial lining is growing properly, I don't think so there is need of repeat. But yes, in difficult cases, you may need to repeat after 4 weeks and may need multiple sittings also.
Okay. So there are some cases which may need repeat hysteroscopy. We need to keep in mind.
Not for
but as routine, we are not going to do it. What about the dose of estrogen to use in a post-surgical? Dr. Surya Kumar Khandare is asking, what is the dose of estrogen?
Ma'am, I am giving 2 mg TDS.
TDS for
at least for 30 days or 40 days till I will get a good endometrium. Mostly for first cycle, I will wait for threshold bleeding. So I will give it for a long duration. Once she will have proper flow, then estrogen for 21 days, then progesterone for 5 days, natural cyclical we will give later on.
Okay, so first will be only progesterone and then you will be
only
adding,
estrogen.
Oh, sorry, only estrogen and progesterone you will be adding in the subsequent cycle after the threshold. Yeah. Okay. Also, if the endometrium is 2 millimeter, Dr. Madhu Arora is asking. So, will you use the same if it's not proliferating or if it's not regenerating the endometrium? Will you increase the dose of estrogen?
Ma'am, it is after hysteroscopic resection.
Yes, the question is actually the endometrium is 2 millimeter.
Ma'am, mostly it grows with estrogen after doing resection. At least some amount of improvement is definitely there. And if you see there is no improvement, we may need to go for hysteroscopy again.
Okay. Definitely. If it is not improving, means you require a repeat hysteroscopy in this case. Okay, now this question is regarding the luteal phase. So the question is, Madam, can low AMH cause RPL? Any role of DHEA? Dr. Sapna Kumar is asking. I think Dr. Kavita can take this. Low AMH as a cause of RPL and any role of DHE.
Unmute.
Yeah, you can unmute your mic.
Hello. Yeah, sure, ma'am. Low AMH can suggest a premature ovarian failure. So,
yeah. Yes.
So the role of DHEA, it's modified and somehow it relates to the folate synthesis cycle, and it improves the quality of egg. And this where the ovarian follicle which is maturing, the quality of corpus luteal form is also very good, and it secretes the optimum amount of progesterone which is required to sustain the pregnancy.
Okay. There is some amount we can consider, but it's better to, as an adjuvant we can add DHEA. It's not like the treatment what we can give. So there is one question from Vijay Lakshmi Shishatri, who is asking that the conceptus in a miscarriage it is difficult. The karyotyping of the conceptus in a missed abortion is difficult as we do not have a live tissue. So, what do you do in those circumstances? And I may also add that how will you transport that conceptus, or how do you ensure that the sample goes properly? So,
nowadays a microarray test is coming in which the product of conception is not required.
Okay. So what? How are you going to send? No, if you have to send concept, see, everybody will not be having the
Yeah.
access to microarray test. There are so many people sending the products of concepts. So how will you collect that conceptors? How it could be sent? Uh,
It
what is
should
the
be
procedure?
sent
Can you
in a
just tell?
normal saline sterile vial and try to remove all the blood clots.
So, Dr. Kavita, it has to be sent in a glucose saline sample along with 2
Okay.
drops of gentamicin and
Okay.
the
Yes.
temperature controlled in 2 to 8 degrees.
Gentamicin needs to be added,
Yes.
definitely.
And there are 3 types. Lately, we had been doing karyotyping, which cell culture was done, and the chromosomal morphology was studied in metaphase stage. Then the fish came up, which has only probes for few chromosomes. Hello? Am I audible?
Yeah,
Yes, ma'am.
you are
Yes,
audible.
ma'am.
Yeah. Then now the latest techniques which we have, like array CGH, and which is combined genomic hybridization, or NGS. Presently, the best results are given by array CGHS. Is that we have two benefits. We don't have to do culture, one thing, and it does not interfere with the maternal genotype. Then another thing is the report is very fast. They give the report within 48 hours, I suppose. And NGS is still being studied, a role for in conceptions in cytogenetics. Hello?
Hello, Dr. Komal.
Yeah, Dr. Komal?
Dr. Kumar.
Hello?
Ma'am, I have a question.
Yeah.
For early pregnancy losses, like genetic causes, like patient has come with 2 or 3, I have a patient who has 8 or 9 abortions. Every time cardiac activity comes and it goes off. The karyotype is normal for both husband and wife. For
Yeah.
fetus also
Whenever,
karyotype is
from
normal.
my personal experience, whenever the fetal heart comes and goes, there are more chances of it being immunological.
Immunological. So we have
One thing
supported
being
her like
culture,
low
and you
molecular
need
weight
to rule out
heparin.
Aplar syndrome, because there would be certain pregnancy losses in which there are
So
no investigations available till now.
her APLA was also normal,
The
but
APLA, you know what, Dr. Kavita, all APLA tests will not rule out APLA.
we have given except low molecular weight heparin 12 hourly to that patient also,
No, did you
pre-conception
give,
and post-conception.
have you
And
got her the,
IVI also. I have
have
tried
you,
IVI also.
right, NK cell level and TNF alpha levels have to be done in such patients.
Okay. And
Yes.
after that, if they also come
नहीं,
normal or
they
something
will
happens.
most likely कोई ना कोई चीज एक पॉजिटिव आएगी, because she becomes your research case.
नहीं, अगर वो पॉजिटिव आएगी तो ट्रीटमेंट क्या है उसका आगे?
देखो मैडम, दो तीन चीजें उसमें, एक मोसेसिज्म रूल आउट करनी है, बिकॉज हमारे पास अभी टिल नाउ वी डोंट हैव एनी टेस्ट व्हिच रूल्स आउट मोसेसिज्म इन प्रेगनेंसीज. So these patients are like the kind of all genetic defects we are not being able to diagnose, one thing. Then you have to counsel the patient for one of the other methods which she has to use,
But I
including
think for
require a
such
PGD
patient,
also.
it's better to counsel her for IVF and go for a donor egg rather than putting all the money in the test like this.
Right. Then another thing is, one, you need to have a DNA sperm, DNA fragmentation of this
Fragmentation.
Yeah.
Okay. We have
Hi,
Dr.
Dr.
That
Sanjay
could
Valida.
be
I can
one
I'm
see.
reason,
so
very
sorry.
common
No,
reason.
the last part of the
I'm
talk, actually, the connection went away, the internet, and we were totally engrossed in the talk, and then we had some few questions of panel which we continued. So you can just share the screen.
okay. Just a minute. 1 second. Huh? I don't know. Manan, just switch on the, yeah, switch the headphones on. Okay. I've shared the screen.
Yeah.
Okay, I'm just going to go ahead fast. Yeah, where was it?
You can go after. No, this all you finished. Second, after the second case.
Yeah, just a minute. Beyond this?
Yeah, we all have done this.
Yeah. Oh, so I'm glad you guys heard most of it.
Yeah, we heard almost.
Yeah.
It was towards only last 5 minutes, I think.
This was very important.
Yes, so we were totally. It was going really very nice, and
Yeah. So I think if you've heard most of it, that's fine. Should I just do the last 2 slides?
yeah.
Hello?
Shall I just do the last 2,
Hello,
3
yes,
slides?
yes.
Yeah, that should. Can you see the screen?
Yes.
Yeah. So I'm
We
just.
can hear you very well.
You can hear me. So I'm
Yeah.
just saying, this is the end, last 2, 3 slides. Instead of asking why do women not accept the service that we offer, the important question should be why do we not offer a service that the women will accept? And remember that women want a positive pregnancy experience, and so do we as caregivers. So my message to everybody is that we have to convince them to register early and to come regularly in the first trimester so that we are able to give them the best outcome possible. And I just want to end with, please support me for ICOG Governing Council elections, which are starting on August 1st. And a big thank you to all of you, and thank you very much, Komal, for giving me the opportunity to participate in this webinar.
Thank you very much, and it was really very nice and a very crisp talk by you, and all points so well covered about the screening, and the first trimester is so tricky. We were discussing a lot of questions even after the panel discussion, which were a lot of questions from all over. The people are asking many. So if I would request you also to contribute to some of the questions and share your experiences. There are many questions regarding the panel also, and I think regarding the talk also I will receive soon. So we can just talk about the questions. Yeah. So it is about. So there is a question by Dr. Sonal Gupta. She's asking whether methyl prednisolone, does it affect the fetal development? A lot of discussion is happening about prednisolone after we lost the connection. So what you can add anything, Dr. Sarita Bhalerao, in it, like prednisolone given early in pregnancy cause any interferes into fetal development?
Yes, well, there have been reports about cleft lip, cleft palate with steroids in early pregnancy. And what our guidelines say is that we have to weigh the pros and cons. And if the patient is on an autoimmune condition which is steroid dependent, then we should not take away the steroids. But otherwise, it's not advisable to give steroids. And if it is possible for her to stop or to wean off, then it's better that she weans off first and then becomes pregnant. I've had patients with skin problems, severe psoriasis, all sorts of autoimmune conditions, and we always tell them that you go off the steroids, stabilize yourself, and then you become pregnant.
Yes. So that is very, very important that we need to use it with caution, the prednisolone, but if we have no choice, we need to use it when required. Also, there is a question from Dr. Mrs. Kamal Bakshi that apply if we have to do, is it have to be done 2 times 12 weeks apart to label it apply, or you can do a single test?
Yeah, 2 times. 2 times, ma'am. It is done 2 times.
2 times?
Hello?
Yes.
It is done 2 times.
It's 2 times 12 weeks apart.
Yeah.
Label it first.
Yeah.
Yes.
Yeah.
So this we should keep in mind. And also a question about the karyotyping. We have actually discussed, and I want Dr. Sarita Bhalerao's opinion in this. Do we need karyotyping of both the parents also, and as well as the products of conception, or we can do either of, we can skip one?
I think the most important is first to do the karyotyping of products of conception. And if we are able to do products of conception, then if there is a genetic abnormality, then one can go for genetic counseling and karyotyping of the parents. If there is no genetic abnormality in the products of conception, then maybe it is some other cause. So one has to do that way. But if a patient comes in the inter-pregnancy time with multiple miscarriages and RPL, then it may be worthwhile doing karyotyping of both the parents.
So the first test would you do is a product of conception first, followed by
Yes,
the
correct.
karyotype of the
Yes.
pregnancy.
Dr. Sarita, I want to ask one question.
Yes,
You
madam.
can ask.
Yes,
What
madam.
is the dose of HQ in case of SLE, dose and duration? tablet.
HQ, hydroxychloroquine.
Yeah.
Well, I mean, I wouldn't prescribe it because it's prescribed by the rheumatologists completely. The only dose of HCQ I know is now for COVID prevention in healthcare workers.
Yeah.
So I don't know.
SLE,
I haven't never
SLE
prescribed.
is the drug of choice.
Yeah. No, there have been patients on, with rheumatoid problems and all who are on HCQS, but usually that is handled by the rheumatologist.
Yes.
Okay.
So this is there. Regarding so much we talk about torch and everything, there is a question from Dr. Kiran Shah. Is there any role of spiramycin in RPA? Do we give spiramycin?
We give in toxoplasmosis.
Yeah, but what is when do you start, or do you give empirically to all your patients, or how do you give in which cases?
If there is
I
a
think Dr.
positive
Mithilesh Bansal
toxoplasmosis,
had spoke about toxo, so you can take the question.
if there are symptoms of toxoplasmosis like skin rash, a sore throat, body ache, and active IgM antibody, then we start spiramycin 300 milligram per day. I think so. Spiramycin.
So only those cases you will give. You'll have to actually select a case where we need to give and not give just empirically to all the patients.
No,
So
no,
that
no.
is
Active antibody is there. Active antibody is there.
yeah. So there is a question from Dr. Neena Soni. Lot of questions. I think there are almost 100 questions here flowing, and I'm just trying to screen out what we have not covered so that we get to answer good questions. So how to measure the cervical length? That is a practical question. You're not specified on an ultrasound or whatever, but can doctor, I think, hello, Dr. Bansal, I think we spoke about cervical incompetence. So can you just throw light on cervical length measurement?
Komal, I'm going to sign up just to say I have a section with.
Okay, yes. Thank you very much, Dr. Sarita Bhalerao, for joining us. And we are in the last few questions of our panel discussion. So let's cover the maximum questions what we have not covered or discussed. So this was about, I was asking about the ideal measurement of the cervical length.
Ma'am, ideally it should be measured by a transvaginal ultrasonography. We have to take the cervical length from the internal os up to the external os, and it should be around equal to 4 centimeters. Sorry.
3 centimeters.
And there should be for good pregnancy, and minimum it is required is 2.5 centimeter. In the books it is given 2.5 centimeter, and there should be no funneling of the membranes or at the internal.
And that's the standard way of doing it. But now the latest studies which are coming up, they are saying that you need to measure the length between external os and the base of the bladder of the cervix. Because at times when we take it from the internal os up till the external os, the length comes out to be normal, but then after certain days, patient comes up with the rupture, leakage of the membrane, lichen.
Yes, and we need to know the right amount of pressure also, because then we will try to exaggerate the funneling effect. So we need to be very careful while measuring the cervical length. So
the studies which have come up lately are saying that need to have a measurement between the external os and the base of bladder.
Okay.
So, ma'am, this is 3 centimeter or 4 centimeter?
3 centimeters.
3 centimeters.
Yeah.
So we usually don't, and usually when the cervical length falls below 2.5 or something, that is the time when we do circlage. Usually if it's 3 centimeter, 3.5 to 3, I think even the progesterones are having a good results. We are not putting a cervical circlage stick unless it's a twin pregnancy or something. So even are you all doing a prophylactic circlage for twin pregnancy there?
Yes,
we are doing routinely.
Routinely for
even
twins.
for and routinely for twins baby or multiple pregnancies, but with a history of leaking PV in the 8th month or 7th month also, we put a cervical and self-touch.
Ma'am, in IVF conceived patients, yes, twins, I'm doing it routinely. I've started putting in now McDonald's stitch now.
In all the twins.
Us,
Yes, IVF conceived.
IVF conceived. Okay.
Yeah.
Okay, and I think we were almost finishing. There is a question regarding role of PRP. So can we give PRP for the endometrial regeneration, doctor, after the hysteroscopy? Asherman's or any cases?
Yes, ma'am, that's got a fantastic results.
Yes.
And another thing is role of GCSF also in patients of immunology. Their role of GCSF is being studied from the 6 days after the LH surge up till the urine pregnancy test is positive until 9 weeks.
No, we're talking about the Asherman's for rejuvenation of the endometrium.
Right, it works. It works beautifully, ma'am.
GCF also works there. Okay. And a lot of questions on LMWH, which we have already covered, when to start and all. We said we need to start before the fetal activity, but if you see it later, you can start. Now this is question from if a patient meets a doctor after the 12th week with positive UPT, can encerclage be advised after 14 weeks? How do we go about the pregnancy to continue successfully? Dr. Varalakshmi Balayan is asking. So I think the patient is a case of an incompetent OS and she's coming at an early pregnancy. So can you do cerclage as early as 12 to 14 weeks?
Yes, ma'am. After the NT scan comes out to be normal and we have a dual marker and both the tests are normal and the patient has a history of the previous cervical incompetence, then we can do a cerclage at 14 weeks, after the 14 weeks.
and I would like to add a cervical and vaginal swab. If they are sterile, then we should do.
Yes, that is a very important point about the cervical and vaginal swab. Yes. So this is also one. There is one last question actually, but I think we have covered it in our discussion. So it may be just a summary of what we discussed. A patient 8 weeks pregnancy loss, primary gravida she is, and in 7th week there was no fetal heart. Now, what investigations to do before planning the next pregnancy, and how many months she has to wait to plan the next pregnancy? A common question. So anybody can take it. So first is that's the primary gravida. It's not like it's a case on RPL, but there is a absent fetal heart, so it's a missed abortion. So
what's the age of the patient, ma'am?
Age is not written. It's a question by our audience. So she is now at 7 weeks, there is a missed abortion. So now she has to plan the next pregnancy. So what minimum investigations which you should actually do? And how much time she should wait?
A day to ultrasound to rule out PCOD. Basically, what is the BMI of the patient, age of the patient, and thyroid and a sugar level. Basically, these are the minimum required tests to plan further. If the age is more than 35 years, as we have discussed in the panel, then we can start up an intensive investigations and treatment for the patient.
And how much time she should wait? We advise her to
3 months.
Wait for how?
Ma'am, in the next cycle also she can conceive. I don't.
No, Dr. Kavita, it has to be minimum of 2 months.
I think to rule out PCOD, we can rule out and thyroid and sugar comes normal, then can, with the folic acid cover of 1 month, she can conceive next month.
So immediately next month you want her to
No, ma'am,
conceive,
Dr.
or will you
Komal,
advise her to prevent pregnancy for at least a couple of months? 3 months,
times,
6 months,
3 months.
3 months?
2 to 3 months, ma'am. The studies say the patient should wait for 2 to 3 months if the age is not the constraint and the AMH levels are normal.
If the patient is young, patient can wait for at least minimum 3 months. But if a patient is an elderly or something, and if you're doing or planning pregnancy through IVF, I think that is a time where we are planning immediately next month. But definitely, if it is just a primary gravida with
But
gestation,
now if the patient is elderly, she can conceive next month, and if she's primary and she's fit and fine,
no, it
then
is
why
not
can't
that
she
way.
try further?
We are not talking about an elderly or anything, but if your patient is already under a treatment, what is she's already undergoing a treatment and she is having a, and we know we have monitored her, then we can actually monitor again. But if there is a primary gravida or some patient who had an
She can
RPL,
wait.
it is better to investigate her after the loss and then allow her to get pregnant. So that would be some gap, would give us time for investigation. That is what is my opinion on it. So I think we really had a good discussion. I think everybody has given, we discussed all variety of cases on RPL in depth. It is a very big and vast topic which really requires a lot of thing, and we had a very active audience, and I think more than 300 people have come with all these small societies. I really feel I have visited the Bhimani, Sirsa, Palwar and Karnal societies, and people from all over, in fact even Maharashtra, South Mumbai, all over India have joined for this very interesting webinar, and they have loved our discussion. We have a lot of positive comments, and it was pleasure being and hosting webinar for you. And on behalf of the sponsors, the Bharat Serum, the Team Science Integra, TOG, and my Foxy Medical Disorders in Pregnancy Committee, I would like to thank each society president, secretary, and all the active panelists who have come here in the evening and contributed to this knowledge of ocean of knowledge. And I thank you very much.
Okay, thank you.
I'm really thankful to you, Dr. Komal, for making me part of this panel.
Society.
It was a wonderful talk.
Society.
Yes, thank you very much. Thank you so much. And it was great
Thank you,
connecting
ma'am.
with all the viewers from this society. And I know that the webinar is happening at some places for the first time, but you really have done a great job. And what it seemed like, the end of the world, and what it was, a lesson to be learned. So a lesson to be learned, and it is a lifetime, for a lifetime. So that is something which is really great. And thank you, Cecil, for this nice images what you have shared. Thank you so much.
Okay, ma'am. Thank you. Thank you so
Thank
much.
you so much.